Good afternoon, ladies and gentlemen. We are continue to study ophthalmology. Our next lecture is glaucoma. You know, it's a great problem all over the world, and today we will try to speak about diagnostic, management, and surgical treatment of glaucoma. Glaucoma is a group of disorders in which intraocular pressure is right above tolerance limit, resulting in a damage to the optic nerve and irreversible visual field defects. Near 70 million of people have glaucoma in the world. Near 7 million of people are totally blind because of glaucoma. And glaucoma is the second cause of blindness and visual disability around the world. So you can see that glaucoma is really great, not just ophthalmological, but also social problem because blind people is a problem for the social. There are a lot of risk factors of glaucoma. We should speak about general like age. Usually, glaucoma affects adult people or even elderly people. For example, open angle glaucoma, which are diagnosed in 80% of the patient with glaucoma. Usually, open angle glaucoma is appear after 60 years old. As for the race, for the black population, the open angle glaucoma is more characterized. As for the Chinese people, we can often diagnose close angle glaucoma. Family history, of course, it's important because if parents or grandparents have glaucoma, then our patient can also have glaucoma. Systemic risk factors are also essential. High blood pressure, increased carotid blood flow, carotid cavernous fistula, plasma hyposmolarity, hyperbaria, diabetes mellitus. And of course, local factors, which are also maybe the risk factors for development of glaucoma. Increased episcleral venous pressure, blockage of ophthalmic vein, blockage of trabecular mesh, restricted extraocular muscles, pathology of accommodation, myopia is a risk factor for glaucoma, cycloplegic agent which can be used in, in different diseases such as uveitis, for example, corticosteroids. Corticosteroids which we use after operations, after traumas. In the case of uveitis, when we use corticosteroids for the long period, they may be the cause of increased intraocular pressure and glaucoma. There are a lot of classification of glaucomas, but usually we divide it on glaucoma, on congenital glaucoma, primary glaucomas, and secondary glaucomas. As for the primary glaucomas, we can divide on primary open angle, primary closed angle glaucoma, and primary mixed glaucoma. This classification according angle depends on condition of the angle of anterior chamber. On this picture you can see open angle, and this picture you can see closed angle. All glaucomas and glaucoma is caused by imbalance between aqueous production and aqueous outflow. Glaucoma, if we speak about primary glaucoma, is a chronic, slowly progressive, usually bilateral disease, which is characterized by ocular hypertension, typical visual field defects, and optic disc changes. We call this capping excavation. And pay attention that these three signs was found by Greffe in 1856. But even nowadays, all these three signs are correct. So you can see how great scientist was Greffe. For all glaucomas, three signs: ocular hypertension, typical visual defect, and optic disc changes. And when your teacher during practical classes will ask you what are signs of glaucoma, you should always say these three signs, and you will be correct. On this picture, you can see anatomy of anterior chamber angle. Difficult structure which help aquahumus leave the eye. I would like we memorize how aquahumus appear in the eye and how aquahumus leaves the eye. So, if you remember that aquahumus is produced by ciliary processes and enter to the posterior chamber here. Sorry, here. Then aquahumus from anterior chamber through the pupil enter in anterior chamber. Then there are two ways for aquahumus outflow. One way, trabecular outflow. Here, aquahumus look through the anterior chamber, through the trabecular mesh, then Schlemm's canal, collector channels, episcleral veins, and leave the eye. There are, another uvascleral outflow. Again, ciliary processes produce aquahumus. Aquahumus goes through the pupil to anterior chamber, one way trabecular outflow, and the second way uvascleral outflow. So the part of the aquahumus goes through ciliary body, suprachoroidal space, and to venous circulation of ciliary body, choroid and sclera. Usually, more than 80% of the aquahumus goes through trabecular outflow, and just Near 20% of aquahumors go through uvascleral outflow. Okay, so another classification of glaucoma from depending on the anterior chamber angle we have already mentioned, open angle, closed angle, and mixed, and according to condition of the visual field, according to visual field defects. Nesterov and Bugin in 1975 divided glaucomas on stages. The first stage, um, mild stage, is characterized by scotoma, which develops between 10 degrees and 20 degrees. The second stage, nasal step or temporal wedge, less than 15 degrees, vision field lost. The third stage, the visual field loss more than on 15%. And the fourth stage, this is a tube visual field or total blindness. Also, we can classify glaucoma according intraocular pressure. Normal intraocular pressure, the intraocular pressure less than 27, moderate elevation 28 to 32, and high intraocular pressure more than 33. Okay, let's speak about primary open-angle glaucoma. I have already mentioned that near 80% of the patient with glaucoma has primary open-angle glaucoma. Open-angle glaucoma is characterized by open angle of anterior chamber with normal gonioscopic appearance. Chronic progressive loss of retinal ganglion cells manifest by optic neuropathy. Also, for primary open-angle glaucoma is characterized by typical visual field defects, and usually this glaucoma affects both eyes, but rather often asymmetrically. Pathogenesis of primary open-angle glaucoma. The cause, of course, is impaired outflow. Usually, the problem is in trabecular measure, though the sclerosis of trabecula and less fluid can leave eyes through this trabecula. Impaired outflow is a cause of ocular hypertension. Then we can see dystrophic changes. Again, more deep sclerosis of the trabecular measure, chronic ocular hypertension, optic nerve ischemia, then atrophy of the optic nerve, loss of vision, and blindness. As for the symptoms of primary open-angle glaucoma, I would like to say that in early stages, usually there is no any symptoms. No, maybe the patient have a slight headache or blurring of vision or colored halos, but it's not a severe situation. Don't forget that primary open glaucoma usually affects rather elderly people, and they sometimes don't pay attention on slight headache or eye ache and to think maybe it's high blood pressure or something like this. And that's why rather often the people with primary open angle glaucoma come to doctors, to ophthalmologists in late stages when we can't help to this patient, and that's why early diagnostic of this disease is a very important part of our work. So let's discuss methods of investigation which can help us to make to suggest glaucoma, to make correct diagnosis. What should we do? We can examine the eye by focal illumination, by slit lamp, and make gonioscopy, examine the anterior angle of anterior chamber. What can we see in the anterior part of the eye? We can see symptoms of emissarium of the in the conjunctiva vessels. In the late signs, symptoms of cobra. We can see iris dystrophy and sectoral iris atrophy. On this picture, by the way, you see the head of our department, Professor Ivanova. She is examining the patient. Gonioscopy, I have already mentioned, examination of anterior chamber, uh, angle of the eye. Of course, you know that one of the most important sign of glaucoma is ocular hypertension, and tonometry is one of the most important methods of examination. Usually, we recommend to measure intraocular pressure once a year for the all people after 40. Uh, there are a lot of devices which can help us uh, to measure intraocular pressure. Nowadays, we use tonometry by Maklakov. When we have anything, we have palpate the eye and estimate how hard is it. In European countries very often use Goldman tonometer. And nowadays, we use rather often who have already attended our practical classes and have opportunity to see that we use pneumotonometers. Pneumotonometers use just it's a without contact method, and we can use just an air to measure intraocular pressure. It's good. It's without contact method, but this method is not um, mm, is not always right. That's why it's more than a screening method. If we see the high intraocular pressure, which we measure by pneumatic tonometer, we can measure this intraocular pressure by contact tonometers, which usually gives us more correct result. Okay, we should also uh, check the visual fields in a patient um, with suggestion of glaucoma. We have already mentioned these visual field defects are very um, often appear in a patient with glaucoma. So there is a control method when we compare the patient visual field with the doctor's visual field, but it's a very simple but rather old method. I hope during your classes in physiology you can use this arc perimeter and can have opportunity to measure visual field. We can use campimeter and we can see nowadays Humphrey visual field analyzer uh, or other devices which can help us to measure visual field using electronic devices. And I would like you to tell some words about visual field defect. Look, it's a normal visual field. Yeah? You can see defects, more defects, severe defects, and just small part of visual field are survive. No, also you can see central scotomas, you can see big central scotoma, you can see tube visual field here also. This result we can receive in modern electronic perimeter, and you of course can see the defects of visual field. We estimate the regional sensitivity to light and look on this picture. Here just increased size of blind spot and central scotoma. But on this picture you can see that just small part of the visual field is survived and other mm, other part of the visual field are blind. Okay, and we should, in a case of glaucoma, in a case of suggestion of glaucoma, examine the optic nerve. Optic nerve we can examine by ophthalmoscopy. It's a rather old method, but still effective, and we can make an examination of the optic nerve using optical coherence tomography. Who was on practical classes, I think, know about this method. I have already mentioned that we usually using ophthalmoscopy, we estimate cup disc ratio in the horizontal and vertical meridian, and it must be 0.3 or less. Here you see that cup excavation increase, here more, here more and more, and here you see that even though the nervous fibers just atrophy. Now on this picture you can see examples um, of cupping excavation of the optic disc in a patient with glaucoma. Look, this, this excavation decrease and deep, and of course, if we diagnose glaucoma in such condition, I think the patient have in such cases rather bad visual acuity and very narrow visual fields. Okay, let's speak about changes of the optic nerve and visual field. look on this picture. Here, just first stage, a bit increase the size of blind spot, and here you see excavation a bit increase. Here you see the big excavation, and visual field becomes worse. Here excavation becomes bigger and visual fields worse, and you can see visual field, just the pieces of visual field we can see, and here we will see total excavation. Let's speak about optical coherence tomography. Here you see the macular area. This is a picture of the optic nerve, disc of the optic nerve. Here on this picture, you see the thickness of nervous fibers. Here you see that thickness of nervous fibers decrease. The thickness must be in green area, and if we receive such picture, we can suggest glaucoma. Okay, so we make correct diagnose glaucoma. What should we do? We should prescribe anti-glaucomatosis drugs which decrease intraocular pressure. We should add neuroprotective therapy, and if anti-glaucoma drugs are not effective, we can prescribe surgical treatment. On this picture you can see the groups of the medicines which we use for local treatment of primary open-angle glaucoma. The first line treatment is prostaglandin analog like salaritan, travatan. Salaritan is latanoprost, travatan travoprost. Beta blockers we can use. It's also first line treatment for glaucoma. Usually we use timolol 0.5%. We can also, but rare, can use miotic drugs, adrenergic agonist, and carbonic inhibitors. So some of these medicine increase outflow, and some of this medicine decrease the production of ectohumus. So usually analog of prostaglandins increase the outflow, but beta blocks decrease the production of aqua fluid. You can see on this picture just several eye drops which we use for the glaucoma treatment. And you can say, why so many drops? It's because of the severity process. We prescribe drops, but not always they are effective. Even every 5 years appear as new drops, but it's a pity. But despite of new drops, despite of new treatment, uh, in some cases glaucoma progress. If the conservative treatment, if the eye drops are not effective, we can add laser treatment. Usually we use argon laser trabeculoplasty to um, to make incision, to make space in trabecular mesh. In severe cases, we can make cyclophotocoagulation. When eye drops laser treatment is not effective, we should make mm, surgery. Oh, I would like to show you the sinus trabeculectomy. The principle is we make incision of conjunctiva, then near the limbus make the piece of the sclera, and here you see we make hole in angle of anterior chamber to give opportunity mm, for fluid to go uh, to leave the eye. Usually this fluid go uh, under the conjunctiva. Again, you see the picture, you see how to use this. Then we put some sutures on this part of the sclera, piece of the sclera. In severe cases, we put in eye different drainage devices which also help to fluid to leave the eye. Okay, let's go further. We should speak about primary angle closure glaucoma. Primary angle closure glaucoma is a condition in which aqueous outflow is obstructed slowly as a result of closure of the angle by peripheral iris. How it happens? Usually, lens move forward, appear pupillary block, and um, aqueous from posterior chamber can't go to anterior chamber. We receive high pressure of the aqueous in anterior chamber and iris bomb, occlusion of trabecular zone by iris, and mm, of course pressure in the posterior chamber and vitreous body increase. Iris contact with trabecular mesh, and we receive total occlusion of anterior chamber angle. We receive total occlusion here. Clinical feature of primary angle closure glaucoma. There are substages. The first, prodromal stage or latent glaucoma. Each attack lasts for a few seconds. Stage of constant instability. In this stage, attacks of rise of intraocular pressure are recurrent, regular, and each attack may last from a few minutes to 1-2 hours. The third stage, acute congestive stage. Fourth, chronic congestive stage. And fifth stage, absolute stage. There are some risk factors for acute and angle closure glaucoma. These are emotional stress, overwork, dim illumination, midriatic drugs, and uh, anatomical risk factors. These are big lens, small eye, hyperopia. Symptoms are for pain, it's a severe pain, it's urgent situation, color halos or rainbows, um, blurring of vision, of course, nausea, vomiting. Clinical signs: intraocular pressure, usually high during attack. When you palpate eye, it, these are very hard, like a stone, and even without measurement, we can estimate the intraocular pressure. The pupil is dilated. We can see redness of the eyeball, cornea edema, or we can, if we can see the angle of anterior chamber, we see that angle is closed. We can see iris atrophy, posterior ciliary in some cases, and we see the small anterior chamber, and if it's possible to see the optic nerve because cornea is edematosis, we can see the carbon excavation or even optic atrophy. On this picture, you can see acute angle closure glaucoma. Look on this redness of the eye, dilatation of the pupil. On this picture, you can see edema of the cornea. Also, pupil is dilated. Of course, the acute angle closure glaucoma is an emergency case, and mm, the patient has severe condition, and we should hospitalize this patient immediately in an ophthalmological department. In ophthalmological department, we should put eye drops, pilocarpine 1-2% each 15 minutes in the first hour. Don't forget. Stimulol 0.5% 2 times a day. We should prescribe painkiller. Um, we should prescribe the medicine which decrease arterial pressure, high blood pressure. We should use systemically uh, inhibitors of carbon hydrase like diacarb, for example. If it's possible, we should immediately to make um, iridectomy. When we make iridectomy, the connection between posterior and anterior chamber reconstructed, and the acute angle closure glaucoma is dissipated. I would like to tell you some words about congenital glaucoma. It's rather, um, it's rather difficult condition, rather dangerous condition. And for example, if you will GP or if you will work with children, you should think and remember about this glaucoma. You should suggest this glaucoma in time, diagnosed and help to children. So, primary congenital glaucoma can be divided into the three types: true congenital glaucoma, uh, which appear in newborn; infantile glaucoma; mm, juvenile glaucoma. Clinical features. Of course, newborn can't say you about the pain, can't say about redness, and so on. Usually, we can see corneal haze, uh, so blurring cornea, not fully transparent cornea, and we can see lacrimation, photophobia, and blepharospasm. If you see such um, newborn, you should send it to ophthalmologist. In the late stages, we can see ophthalmos or big eye. We can see glaucomatosis, cupping, excavation of the optic nerve. But the early symptoms um, are rather simple: lacrimation, photophobia, and blepharospasm. And don't forget about congenital glaucoma. Look on this picture. Here you see big eye, ophthalmos, yeah? And this picture, you see the cloudy cornea, opaque cornea, and of course, in such case, we can't help to this newborn to save vision. And usually, the treatment of congenital glaucoma is surgical. Before surgery, of course, we can prescribe some anti-glaucoma drops, but it just for the time for the preparation for surgical treatment. I think you enjoyed the lectures. Thank you very much for your attention, and hope we will continue the discussion. We will continue to speak about glaucoma during our practical classes. Thank you very much and goodbye. Good afternoon, ladies and gentlemen. We continue our ophthalmological lectures. Today is a very important and interesting topic: diseases of the lens. Before we start to speak about the diseases of the lens, I would like we remember the anatomical structure of the lens and its function. I hope you remember that the lens is transparent, biconvex, crystalline avascular structure placed between iris and the vitreous body. So here is the lens, yeah. Accommodative power of the lens near 20 dioptries. I hope you remember this is the second refractive powerful structure. The first is cornea. Its refractive power is 40, no, near the 40. So the accommodative power of the lens near 20 dioptries. The thickness of the lens near 4 to 5 millimeters. A lens consists of proteins and water. On this picture, you can see the position of the lens in the eye. So, lens is situated in posterior chamber. At contact with the iris anteriorly, and here is anterior chamber, here is the pupil, and lens contact mm, with the vitreous body posteriorly. Anatomical structure of the lens: anterior capsule, single layer of cuboidal cells, lens fibers, nucleus and cortex, and posterior capsule. All the structures, knowing of all the structure is very important of the lens surgery. We will speak about this surgery a bit later. Now we should speak about anomalies of the lens. We can divide all anomalies on cataracts, displacement of the lens, and congenital anomalies of the lens. Today, of course, we couldn't speak about all diseases of the lens, but we should pay attention on more important. As for the congenital anomalies, you could see lenticonus, lens coloboma, micro and spherophakia, biphakia, aphakia, remains of the fatal hyaloid vascular system, and remains of hyaloid membrane. Any opacities of the lens we call cataract. On this picture, you see normal, transparent lens. On this picture, you see the cataract, so opaque lens. Of course, you know that light goes through the cornea and lens to the retina, and if the lens is not transparent, of course, this situation is affect visual function. Cataract is rather often situation, and you can see cataract in many patients, in many people. That's why we should speak about classification of the cataracts, about treatment of the cataracts. And at the end of the lecture, I think we will have opportunity to see, to watch the short movie. Okay, so anatomic localization, according to anatomic localization, we can divide all cataracts on anterior polar, posterior polar, spindle-shaped, lamellar cataract, nuclear cataract, cortical, posterior subcapsular cataract, and total cataract, when opacities uh, are affected all lens. According etiology, we can divide cataracts on senile or age-related. To tell the truth, um, this is more often cataract. Many people after 60 have cataract. Congenital cataract, traumatic cataract, associated with intraocular diseases like uveitis, glaucoma, different retinal degeneration, and other diseases. Cataract may be associated with systemic diseases like metabolic diseases, for example, diabetic mellitus, renal diseases, skin disease, connective tissue disorders, central nervous system diseases. And cataract may be caused by different pathological agents like radiation, X-ray, for example, microwaves. Uh, Cataract may be caused by mm, different medicines like steroids, for example, different myotics, eye drops, and other some other medicines. Clinical features of the cataract rather simple. So the patient mm, can usually complains on bad vision. In some cases, he can complains on glare, colored halos, black spot in front of the eye. The patient can say that image become blur and in a, in a last stages the patient can say you that he has loss of vision. Look on this picture. In this picture you see how the normal eye can see. Here you see how the patient with cataract can see the same picture. Signs. Mm, When we suggest the cataract, or we should check visual acuity, of course, in patient with cataract visual acuity decrease, of course. Test we can make test of iris shadow, oblique illumination examination, uh, direct ophthalmoscopic examination, and of course slit lamp examination uh, or examination with biomicroscope can help us to make correct diagnostic. On this picture you can see how what can we see uh, using the slit lamp. Look, we look in a slit lamp in biomicroscope. During your practical classes you can see this device. Some of you um, have already started ophthalmological classes, so you can see cornea, uh, then transparent anterior chamber, and this is lens. You can see all structures of the lens, and if there are any opacities, you can see these opacities without difficulties. Okay, congenital cataract occur in a variety of morphologic configuration, including polar, nuclear, lamellar, diffuse, polymorphic, anterior, and posterior cataract. So, according the location, congenital cataract may be in very great differences. Look on this picture. This is the nuclear cataract, nuclear congenital cataract. Here we see this cataract by slit lamp. This is like a chart how this nuclear cataract can see. These are pictures with the examples of congenital cataract. Look, This is a nuclear cataract. This, I think, also nuclear cataract. This is small mm, dot. I think this is polar cataract. Here, you can see here not just the cataract but also iris anomaly. Congenital cataract also not just mm, single disease, but in some cases this is just one signs of different syndrome. For example, I hope you know Marfan syndrome, and in this syndrome, uh, the patient um, has skeletal uh, anomalies, cardiovascular anomalies, and ocular anomalies. For this Marfan syndrome, very mm, very often we can see ectopia length, increase corneal diameter, and increase the size of the eye. We can see flattened iris surface, and we see the small myotic pupil, high myopia, maybe glaucoma, megalocornea, and nystagmus, and of course opacity of the lens, but also not just opacity, but dislocation of the lens. So when you see, I mm, I would like to you don't forget that if you see congenital cataract, don't you should think about different syndromes. Again, syndrome, well, Marchesani syndrome, and in which also patient can have cataract, but also this syndrome is characterized by brachymorphic mm, with short suture and stubby hands with stiff joints. And for this syndrome, microphakia and spherophakia are rather often. Also, myopia, cataracts, microcornea, megalocornea, and angle abnormalities have been reported. Ray's syndrome also have cataract. In this syndrome, patients also have cataract and also have usually have changes in iris. Uh, Gregg syndrome or congenital rubella syndrome. In this syndrome, cataract may be associated with retinitis pigmentosa, microphthalmia, mesodermal dyskinesis, glaucoma, squint, and other pathology of the eye. For these syndromes, pathology of the ear and heart is rather often. Okay, so again, I would like um, to say you that if you see the congenital cataract, you should examine this child very carefully. You should send this child to other specialists to exclude the general pathology and to exclude the syndrome and other problem. Okay, let's go further. We will speak about senile or age-related cataract, and this cataract, um, to add anatomical classification, can be classified according to maturity. We can divide all cataract on incipient cataract, immature cataract, mature cataract, and hypermature cataract. This classification is rather important for surgeon who is going to make cataract surgery. Okay, on this picture, you can see examples of the cataract. Look on this picture, it's a mature cataract, so all structures of the lens are opaque, and when you examine the patient, you see just a gray pupil. On this picture, you can see hypermature cataract, slight lens dislocation. Oh, on this picture, you can see the difference between immature, and mature cataract, but I think it's not so important for you. You just have to know that um, this classification is exist. I would like to say more pictures. On this picture, you can see different types of the cataract. It's immature. These are examples of mature cataract. So, of course, you can see that in these, if the patient has such cataract, he can't see nothing, and he has very bad visual acuity. To tell the truth, nowadays, thanks goodness, we rare see such cataract, but in some cases, uh, when the patient come too late to ophthalmologist, we can see such cataract. To tell the truth, nowadays we try to operate the cataract early when the lens is still transparent, no, not full transparent, but not totally opaque. And in these cases, it's easy to operate, but when we see so opaque lens, it lens is hard and usually difficult to operate such cataract, but we will discuss this further. Okay, again examples, different cataracts. Okay, we have already mentioned that one of the cause of the cataract formation is diabetic mellitus, and in some cases the patient can have diabetic cataract. And I hope you know that a lot of uh, people in old age have diabetic mellitus. But when they have cataract, we don't have that this is true diabetic cataract. It's just a cat or age-related cataract or senile cataract in a patient with diabetic mellitus. But true diabetic cataract usually mm, uh, is appear in a young patient with a type 1 diabetic mellitus or with mm, severe general problems. The most common ocular manifestation of diabetes are bilateral cataract, retinopathy, lesion of optic disc. It's characterized for types 1 diabetic mellitus. A special time of diabetic cataract is a special type of cortical cataract has been seen in many diabetic patients with type 1 diabetic mellitus. Usually is bilateral process. Tetanic cataract, this is condition usually the result of accident removal of the parathyroid glands during uh, thyroidectomy. Also, it may be idiopathic. The lens develops multiple small, white or multicolored punctate opacities, usually located in the subcapsular region. Cataract caused by rheumatoid arthritis. Uh, it's rather rare, but and usually this cataract we can see in a patient with iridocyclitis or uveitis. And then such patients with rheumatoid arthritis also have cataract. Treatment of cataract. Today I have already mentioned some methods of treatment, but if we know the cause of the cataract formation, we should treat the cause. For example, if it's a true diabetic cataract, we should treat these diabetic mellitus to prescribe normally insulin therapy and correct um, other structures such as lipid levels and other metabolic disorders. But in a case of age-related of senile cataract, we know the cause, but we can't treat this cause. Sometimes in initial cataract, for example, we can prescribe different drops to which delay progression of the cataract. There are some eye drops like oftankatafochrome, Quinax, and so on. But to tell the truth, mm, we can't say that these drops are really effective. If they would be effective, we don't have so many cataract surgeries. That's why mm, the most important way of the cataract treatment, of course, surgical treatment, surgical management. Mm, I would like to say you some maybe historical methods, but you should know about them. Intracapsular cataract extraction, when we remove whole lens with the anterior and posterior capsule and nuclear and cortex. Extracapsular capsular extraction, when we make a hole in anterior capsule of the lens, remove nuclear and cortex, and then implant intraocular lens in this capsular sac. And after this operation, patient have rather good visual acuity. Phacoemulsification is the example of extracapsular extraction when the also small incision we make in anterior capsule of the lens, but um, lens nuclear and cortical of the lens extract by special phaco machine with the ultrasound, vacuum aspiration and irrigation. Now again, pictures for you, traumatic cataract, you can see. And on this picture, I would like to describe you how we make extracapsular cataract extraction. So, small incision, yeah, of the cornea with a special needle. We make hole in arterial capsule of the lens. Then we remove lens, then wash uh, sac, lens sac, and then implant special intraocular lens. On this picture, you see the same method, but using the fake machine. After removing the lens, it's necessary to implant into eye intraocular lens. It's important because mm, if we don't put inside intraocular lens, the patient uh, will have to wear very big glasses, near plus 13, and you can imagine how it's inconvenient. So we calculate intraocular lens using the indexes of the cornea, the size of the eye, and we calculate the refractive power of the intraocular lens. When we remove part of the anterior capsule, uh, cortex and nucleus of the lens, we save the posterior capsule of the lens. But the posterior capsule of the lens also may become opaque. And in this case, if the posterior capsule become opaque, we make YAG laser posterior capsulotomy. It's an outpatient device just using the laser explosion. On this picture, you can see the correction of aphakia. So aphakia, it's a condition without the lens. You can see the correction by soft contact lens, by hard contact lens, and with the glasses. And now I will try to show you, sorry, I will try to show you the video, okay, the video of the cataract surgery. This video was made in our clinic in Oka Center just some days ago. I have already mentioned that cataract surgery is a routine operation, and every day in our clinic, for example, we made 6, 8 cataract surgeries. And this is the example of the surgery of mature cataract. You have already seen that cataracts was totally opaque. Lens was totally opaque, so it's mature cataract. And a doctor made, made 2 paracenteses, and then uh, he he add in anterior chamber special solution to color anterior capsule of the eye of the lens to make it visible. Then it washed the eye. This is a viscoelastic. It's a special solution which help us to save to save cells of endothelium during the operation. And look, now the surgeon makes the hole in anterior capsule of the lens. We call this hole capsular rhexis. You can see on this surgery that before surgery we should dilate the pupil to make the lens is good visible. It's important for cataract surgery to make mydriasis. For mydriasis, we use a special mydriatic drop, like tropicamide, for example, 1% tropicamide. Okay, the doctor very carefully using the forceps, special forceps, try to make the hole in anterior capsule. To tell the truth, it's not so easy because of the very mature cataract. It's easy to work in a cataract immature, but I would like you to show not just ordinary case. This case rather complicated, and you can see you can have opportunity to see as a very interesting case. So the surgeon add viscoelastic and try to continue surgery. I would like to say that microscope with the camera give us opportunity to watch operation after surgery, to show these operations for you. Okay, and surgeon make additional incision and cut the anterior capsule. Okay. Very interesting cases. The capsular rhexis should have a very round shape, and it's important for future emulsification of the cataract. Okay, well done. You can see here is the capsular rhexis, and the surgeon removed the anterior capsule of the lens. So now the surgeon move the nucleus of the lens, add again viscoelastic, and pay attention. This is a special device which helps us using ultrasound to remove these glands. The surgeon wait, and now you can see how the surgeon will start to make phacoemulsification. Using ultrasound and vacuum, he should cut the lens and then to remove these lens pieces. Okay, you can see. To cut and eat the pieces of the nuclei of the lens. Believe me, that it's not easy to make it in this hard nuclei. But our surgeons in our clinic are very experienced. Mm, to tell the truth, personally, me, I don't make cataract surgery. I'm excimer laser surgeon, but in our clinic, the cataract surgery is made mm, by the head of the clinic, Rasin Oleg Grigorievich, and he is also a teacher, a lecturer from ophthalmology department. So the students who will be study in who will be have your practical classes in our clinic will have opportunity to see such operation in a real time. So the nucleus of the lens has already removed. You can see now the red reflex from the fundus of the eye. Um, so when we see the red reflex, it's easy to operate. And now the surgeon using the aspiration and irrigation will remove the cortex of the lens. Mhm. Piece by piece, step by step. The main advantages of the phacoemulsification is a small incision, and after such operation, the patient can go home without any inconvenience. So these small incisions make cataract surgery um, is ambulance surgery. Mhm. Okay, the surgeon tried to remove all pieces of the cortex, or if we leave um, some cortex in eye, uh, these pieces of the cortex uh, will be opaque, and we should go to the operation theater again and remove these pieces. So it's very important to wash everything very carefully. Okay, a little bit more. So the surgeon has already removed the nuclear cortex of the eye of the lens, and now it's time to implant the new artificial intraocular lens. The incision is small, but lens is rather big, so we use the soft lens. Look, this soft lens the surgeon put in a cartridge and will implant this lens, fold the lens, and implant. Now you will see the process of intraocular lens implantation. Mhm. Okay, look, 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 look. Very small incision, and you see the lens is rather big, and the purpose to put all part of the intraocular lens in posterior chamber in capsule sac. The surgeon work very carefully. When you look at this video, it seems to that it's so easy to operate, but believe me, it's really, really very difficult. It's microsurgery, and it's really very difficult to understand how to work by microscope, and it's very important. Maybe somebody mm, in your groups um, would like to have would like to study ophthalmology, would like to be ophthalmologist, and I think this is a very good idea, and this is a very good part of the medicine. Very interesting discipline and very interesting surgery. Okay, the surgeon implants the intraocular lens, and I think he's going to finish his work. Yeah, he closed uh, incisions by a physiological solution, saline solution, and you see 15 minutes, and patient will have absolutely new vision. Surgeon check intraocular pressure and closed the last incision. No, uh, usually we don't pay sutures, but in some cases we can add small suture. Okay, the doctor decided to make a small suture for incision because the case was not so easy, and it's better to close the wound carefully, and he decided to put just a just a small suture. You can see the suture is very small, and you can see how the ophthalmic surgeon use instrument to make suture. Mhm. Okay. Mhm. At the end of the operation, the surgeon usually make intraocular subconjunctival injection of antibiotic and corticosteroid. Okay, I think this is all. Very good results, and I would like you to say thank you very much for your attention. I hope you you liked the cataract surgery, and maybe somebody would like to be ophthalmic surgeon. You're always welcome. See you in our practical classes, and goodbye.